Yeah. Good afternoon, everybody. Great to see you all. I'm Emily and I'm the Health Promotion Program Manager. So I get to have a bit of fun in sharing some more colourful slides with you and talking about our health promotion campaign, also known as Eat Your Right. All right, so this session, we're going to showcase our Eat Your Right campaign. We're going to acknowledge the very thorough and in-depth work of our national reference group, which designed the campaign. And we're going to have 3 showcase studies to show off how it was implemented across Australia, which was tailored in each different area. Louise is going to provide a snapshot of our evaluation strategy, and then we'll be having a panel discussion. So please think of any questions that you'd like to ask the implementing team, because we will be inviting our speakers up for a panel session. So our speakers that are going to share their case studies of rolling out the campaign, I'd just like to acknowledge them now. We've got Sel from the NTARC team in Northern Territory. We've got Isha Layden from Quinn, and we've got Rochelle zooming in from Nua in New South Wales. And then we have Louisa talking through evaluation. So we've got a great session to show off what we've done. So I am focusing on the health promotion arm, and we designed a health promotion campaign known as Eat Your Right. And the campaign was built to increase testing and treatment of hepatitis C in people who inject drugs, and with a very particular focus on people who currently inject drugs. We wanted to reach people who are not accessing Hep C testing and treatment services. So we really wanted to engage people who don't normally come in. And we wanted to shift perceptions around Hep C treatment, and also to support people through the testing and treatment pathway. So listening to Uncle Ringo this morning, I really heard that how important it is to walk alongside people. And I want to go into a bit more detail around how we did that with peer-led outreach activities. So I think part of our success has been that we used a peer-led approach right from design through to delivery. And we worked in partnership, and we couldn't have done it without the partnerships of ABLE's national peer network, and also the support of ABLE as well, and our member organisations. So I just wanted to share one of our insights that we discovered early on in our design workshops. So I want you to sit with this because it kind of really contextualises how we designed our campaign and how we rolled it out. So our audience for the campaign was people who currently inject drugs, and that could be delaying or avoiding treatment. And we understood our audience may be criminalised, marginalised, and don't get their drug-related information from mainstream media. And they might also distrust significantly mainstream services. So this really shaped our strategies, and it shaped our discussions. So our campaign strategy is really focused on addressing the stigma and discrimination very much connected to injecting drug use, and making our peer-led conversations really the cornerstone of our campaign delivery. So really often people think about health promotion, they think it means a shiny new resource. So I really want to emphasize in our session that we went beyond creating a shiny new resource, and we paired it with a combination of strategies. But I would like to put a disclaimer to that, saying we did make a pretty awesome shiny resource. We can't help ourselves. So I'll talk through our campaign strategies. So we really wanted to shift perceptions, and to do this, we had paid street advertising. And also this worked together with service posters. You can see the posters up on the walls. But the advertising featured in many different spots. So I've got some photos to show that off. We had it on buses, train stations, massive billboards in city centres, awesome picture of Isha from Quinn, in some bathroom in a shopping centre. Isha did a great job. I think Isha might take the prize for stalking the campaign around Queensland. But when we were kind of planning the advertising, you kind of just think, okay, where's the best spots to put it? So we actually spent a lot of time with the peers fleshing this out and having conversations going, okay, where do people go? Where do people hang out? Where's the popular commuting spots? And then also then what services are people using? What pharmacies are they going to? Is it GP centres? So that's how we really tried to pair where things would go. So if people are going about their daily business, maybe they're popping into the supermarket, maybe they're going to the pharmacist for a script, we would hope that they would actually see a poster for our messages multiple times in that day. So to shift perceptions, we really had to craft our messages to address the misconceptions about Hep C treatment. You can see our messages are very vibrant. They have a rights-based approach to them. They're confident, but they're also addressing the gaps in people's knowledge. And obviously that's that people can get treated while they're using. They don't have to stop, and people can get treated multiple times. So there were some really key information gaps that we wanted to make sure people walked away knowing that they can get treated. Now, on all of the advertising and the posters, our call to action was referring people through to their local peer-based organisation, and that was tailored in each jurisdiction. So it could have been pop into your local peer organisation or call a mobile, text a peer. It was tailored depending on what we knew about our audience in each state and territory. To pair with the advertising, we also had a range of merchandise goodies. So this, you can see all the t-shirts that we designed for the campaign. And I just want to do a call out. If you would like a t-shirt, we've got some sitting out in the tea and coffee area. So you can grab yourself a t-shirt, please help yourself. And then the merchandise with things like tote bags, tourniquets, soaps, sunscreen. We had a range of things to give away to people. And really this was about stimulating different kinds of conversations with people. It's not always easy. We think about peer outreach or peer engagement. It's not always easy to walk up to someone in a random spot and start talking about Hep C. So the merchandise is a way of starting conversations. And to shift perceptions and to share our messages, we also developed a great series of personal treatment stories. So we had 3 wonderful people share their treatment stories. So we created a little set of films that could be shared both through our it'salright.com.au website and a set of videos that could be shared through social media. So you can see some of those videos being shared on our implementing organisations pages. So now I just want to highlight our strategies that we use to really support people through to testing and treatment. So massive focus of our campaign strategy was peer outreach and engagement. And so this was about going off site. So many of the peer drug user organisations that were implementing partners, many of these organisations do have NSPs, do provide testing and do provide treatment. But what the peer outreach was about was getting off site and trying to engage people off site and engage people in conversations and then link them through to the testing service. So part of the health promotion campaign funding, we actually provided funding to our implementing organisations, and it's really about emphasising how can we do something different, how can we engage people in conversations in a different way. We also had incentives as part of the It's All Right campaign, and this was something that we designed together, and it was really identified as a key priority that people need support through the testing and treatment pathways. So ECA Australia also provided funding to support incentives to be used for the campaign rollout, and this was done and tailored in different ways. So each of the organisations that used the incentives really built upon what they knew worked in their local area and tailored the amounts. And you'll hear a bit more about that from our case studies in a moment. So it's pretty exciting because we rolled the campaign out through this year. So it's very exciting because we had a very long design period. So it was fantastic when we started to see it all kick into action. So we had a staggered launch in each area. And we started in April, so Queensland, South Australia and Northern Territory kicked off first. So well done to those 3 areas because it was all new to us and we learned a lot from it. The campaign was a 3-month burst of activity. So with the advertising, we really wanted the advertising to act quite heavily at the start as a prompt or a warm-up, and then the peer outreach activities would really kick in and link people into treatment. The campaign was implemented in partnership with 9 peer-led services and organisations, and then Anglicare and with Megan Hughes, I'd like to do a little shout out today, Sexual Health in Tasmania. And look, the partnerships have been fantastic. So I just wanted to highlight, you can see the logos of each of the organisations that we worked in partnership with. Huge amount of effort. So I really want to thank each of these organisations. There was one person really driving the implementation of the campaign from each organisation, but I want to acknowledge it was a team approach. So campaign took some planning before the 3-month period occurred, and obviously there's an intense burst of activity through that 3 months, and now we're kicking into the evaluation phase. So I do want to thank everybody for their time and effort, because I know people have worked very hard on rolling the campaign out. So now I'm just going to shift gears a little bit and talk about the design of the campaign. I'd like to acknowledge the National Reference Group. So you can see here the members of our National Reference Group. So ECA Australia and ABLE co-chaired the reference group to design the campaign. Thank you, Elisa, for acknowledging the lovely Jude Byrne. Jude was pivotal to kicking this all off, and it was lovely to work with Jude and get to know her. But I'd also like, from the National Reference Group, I'd also like to thank Lisa Bajana, Judy Gold, Peter Higgs, Jackie Richmond, Maria from Hepatitis New South Wales, Angela Corrie, Sione Crawford from Harm Reduction Victoria, Troy Combo, Louisa Walsh, and Shannon Christensen. So they've all been a big part of the National Reference Group over the last, 3 to 4 years. So it's been a really committed group. And then I'd like to do, we're going to do, I have to work on my animation skills. There we go. We got there. Is there more? There's more. Look, all these names you can see here, these are the members of the National ABLE Peer Network. They put in a huge amount of effort into our design workshops, and they were very patient as we got delayed by the pandemic. We all grouped together to work online, and I'll talk a little bit more in a moment about our co-design process, but there was lots of conversations in and out of the workshops. So again, a huge amount of effort went into designing this campaign. The campaign looks awesome. There was a huge amount of work to get to that point, so I'll talk that through, but a special shout out to our peer members. All right, so just quickly, I'm not going to talk too much about the co-design. I think we're all familiar with the term, but we did one face-to-face workshop pre-pandemic, and then we worked really hard online with 12 workshops throughout. I can't even remember the years, but we worked intensely, and then would go into a round of focus testing with our messages. So we conducted 3 rounds of focus testing with our audience, so people who inject drugs. So the peers spoke to close to 280 people. So that's with 3 phases of making sure our messages were going to connect with people, create trust, and generate interest, and give people hope that doing treatment is possible and it's not too hard. The co-design work really meant that we made shared decisions together. We challenged and supported each other. We constantly had to review what we're doing and remain committed. So again, I want to acknowledge the commitment of these, of our reference group and the organisations to rolling this campaign. So some of the challenges with our design, it's so nice to be in a room face to face. I think we all know it. You can work online, it is possible. But some of the challenges is that it's not the same as being in the room, where you can't be maybe as creative with tools that you might have in a room. And you face all the same challenges in a room in terms of how do you make sure that everybody gets that time to speak in a short amount of time. So I just wanted to acknowledge that. The other challenge that we had was designing a national call to action that would create trust and action. And I want to kind of bring you back to that earlier quote We know that people are not going to pick up the phone and always call a 1-800 number. That wasn't an easy referral point. We wanted to try something different from just referring people through to maybe their local pharmacy or GP, because we know that people are not going to walk into those services to talk about Hep C treatment. There's too much stigma and discrimination still for us to use that as a national call to action. And so that's really what kind of led us to channeling people through to a peer-led organisation where there is trust and support, and those peers could then support people onto the next step. And then one of the other challenges I just wanted to recognise was our compressed time between the end of a design phase, where we locked in our messages, we locked in the look, we locked in our incentives and peer outreach. We really had to go into a compressed period of time of actually producing all our films, our videos. Enigma, our media company, who've been fantastic to work with, had to produce every asset that went on a bus, on a train station. You know, that was a huge amount of work. So we had a quick turnaround in going from design to let's implement this and roll it out. So I'd just like to acknowledge our celebrations. We have rolled out our first peer-led developed national campaign, and that's an awesome achievement. I think one of the best things about the campaign is it can wrap around services around what they're already doing, but it has also meant that we had the flexibility to try new things as well. And I think that's always good when you're not fixed into a very set structure on a national, when you're rolling a national campaign out in different areas. We use bold, confident, empowering messages across our advertising and our peer-led messages. And I think the other celebration, which Troy and Colin will be presenting on tomorrow, is we had the opportunity to respond to our focus test results and to extend the work of It's Your Right to have specific messages and artwork for our First Nations audience. And that was really pivotal. And I think we should be really proud of how we responded to that and then rolled it out. And you'll hear more about that tomorrow. So just quick acknowledgements of support. I'd like to acknowledge Paul Ramsey Foundation and also the Australian Government Department of Health, who also funded and supported the rollout of the It's Your Right campaign. All right, so we'll move on to our next session. I'd like to invite Sal up to the stage. Sal's from NTARC in the NT and is going to talk through how she rolled out the campaign. Oh, okay. And we're just going to check on what we're doing with slides. Shannon, are we? Oh, it's all there.
Oh, beautiful.
Oh,
great. Hi, I'm Sal from Darwin. I rolled out the It's Your Right campaign from NTARC in Darwin. So I'm a peer non-clinician, first time I've ever worked within a health setting. Now that I've been in my role for about 18 months, I feel a lot more confident in disclosing the following. I am a peer with a lived experience of 30 plus years of IV drug use and having had hepatitis C. Oops, sorry. I just need to know how to scroll that. Could you please help me? Yeah. I just want to see the rest of my notes. Yeah.
It does get a bit tricky. Oh.
There's no mousey.
No. No, that is tricky. Any tips from anybody about when we don't have a mouse, how to scroll through our speaker notes? This is the IT juice.
Sorry.
Yeah, just keep it.
Oh, you want your notes to be bigger?
Yeah, I just want to be able to read.
How do we slide?
That's all
through
right.
those?
Where's the?
Yeah, that's all right.
Good. Yeah,
Oh.
because two screens.
Yeah. There you go. So
Excellent.
There you go. Just this one.
Thank you very much. Thank you.
There's also a laser pointer for the pointers on here.
Oh, great. Thank you so much. Well, there's a big bomb to drop and then you know, I'll carry on. Some of my experiences were absolutely horrific. I remember when I was told that I had Hep C, and that was the end of my consult with that health professional, and the news was still seeping in as I entered the reception area of the medical centre, to which I collapsed and wasn't given any other advice or info, and some months later received an appointment time to see a specialist at the Royal Adelaide Hospital. So it wasn't, I remember all of that stuff. And that's what I take on when I consider what we're doing when we're working with our clients. So I try and do stuff not over the phone. Really hate to not have to give someone their results over the phone, and recall those experiences that I went through myself in how we engage. Oh, goodness. Oh, there we go. The nurse peer model of care is how we delivered our service, with a client-centered approach being our focus. But it's going to be more to come on that when Angie, Everett and myself deliver the nurse model partnership later on today. So the clinic was already, we had a Hep C clinic already established in NTARC, and had been operating previously on a once-a-month basis. I'd been handed the freshly fed and changed baby by Pete and Shane with their 2 years prep, even before I come along. I was employed at NTARC. So we launched a weekly walk-in clinic with no appointment necessary, allowing for spontaneous testing of NSP clients on a clinic day. And a big win for us was having the access to incentivised testing. The campaign was pushed out primarily through the NSP site with really good results. The merchandise was well received by clients. We made it up into a show bag kind of goodies, and it quickly went out the door. I also tagged along with fellow NTARC staff that were refilling the free condoms in public toilets, and most of those sites we had is where Sharps containers were. So we found that was ideal to be putting up our posters as well. And here's Angie and I showing off on World Hep Day at the NT Government Health Department. We did a presentation. All the merchandise there on a slideshow that we're giving. So these are our numbers. 195 people were spoken to regarding the campaign. Of those 195, 55 were tested within the 3-month time frame, and 21 of the 55 were Indigenous. The challenges and successes. The challenges is the nature of the NT and our clients. We have quite a transient population, which is a very small population spread over vast different distances. We're wanting and needing to be able to provide a service to remote populations and struggling with the logistics, but we think we did quite well. Battling stigma within rural and remote communities with small town views is always a real challenge. Testing and treatment not being a priority for people struggling with so many other issues in their lives. And this one sort of crosses over into the challenges and successes, is having to do the myth busting and spreading info about how improved new treatments are. The successes, a huge advantage I've realised of having a clinic on site and nurse on site of an NSP, where it's a safe space for IV drug users. I'm one of the successes. Meaning peers, peer being the conduit between the NSP and clients and the nurse. And the incentives were the huge success in getting us to be able to build a rapport, grab the attention, and maintain contact through the treatment period. And this is me with some of the good old boys in the clinic there. I'd just like to say it's been a wonderful opportunity as a peer to be able to engage in such a campaign. I love my job. I love being able to show so much care and service IV drug users. I love all my co-workers. I love Angie. And thank you very much.
So, yeah.
Oh, okay.
Yeah. Thanks, Sal. Thanks for sharing the love. Next, I'd like to invite Isha Layden from the Quinn team up in Queensland to come up.
Thank you. Hi everyone, I'm Isha Layden. I'm a peer harm reduction worker at Quinn, which is in Queensland. I didn't think about telling my personal story, but since Sal has, I'm still an injecting drug user in the drug using community, and I have had Hep C for 20 years and then eventually did the treatment. So I think with my experience, it connects with our clients. I've also been incarcerated a few times, so it works really well with our clients that come in. So I'd like to just acknowledge the support of the following, the Paul Ramsey Foundation and ECA Australia. So what Quinn is, Quinn is an independent non-profit providing a range of specialist social and medical services relating to drugs and alcohol and mental health. So we've got Quinns from Townsville, Sunshine Coast, Brisbane and Gold Coast. So I'm the Queensland representative for It's Your Right. Woo, Queensland! So at the start, preparing for the campaign, holy guacamole, didn't know where to start. So we just thought with the advertising, where the heavens is all this advertising going to go? So thinking about it and how I was actually going to roll it out. So I thought I would roll it out with our main Quinn offices, the ones that have NSPs connected to them. So it was rolled out with Burleigh, Southport, which is just an NSP, but Burleigh is one of our main offices, Bowen Hills in Brisbane, Sunshine Coast and in Townsville. So then I thought, how the heavens are we going to like do this, you know? So I got in contact with the different officers and spoke to some peers, and some peers were like, yeah, we're going to do this. Like, this is cool. Like, let's do it. So I was like, okay, awesome. So I had a peer in Townsville. I had a peer on the Sunshine Coast, and I had to split myself in half and do Gold Coast and Brisbane, but eventually did it. So then the challenge was distributing the posters. And I thought, holy guacamole, like I don't even know Townsville and I don't know the Sunshine Coast. So where are we going to do these posters? But anyway, we got through it. So this is where we just distribute most of the posters in Queensland. So as you can see, the local needle and syringe, ATODs, which is alcohol and other drugs, probation and paroles, OSTs, community centres, chemists, sex worker organisations, rehab, sex shops, youth services, drug services, hospitals. I even went up to the police and gave them posters. So that's why we've got police and court services, medical services, and of course, Aboriginal and Torres Strait Islander services as well. So these are the posters that we had in Queensland. I know that other regions had different, some different slogans, but with our call to actions, it was mostly just give a peer a call, you know, very brief. That was quite hard to decide what we were going to have on the posters. Thanks, Emily. You know, I thought we could just all have the same, but as she said that we had to change them for each region. So then we got the Aboriginal Torres Strait Islander burst. So these are just a few of the posters that we got there. And I was like, oh my gosh, where are these posters going to go? So had to, you know, give them to the different regions and talk to the other peers and figured out where we're going to put them. But of course, they all went out like hotcakes, which was good. So then we actually launched the campaign. Well, the 11th of April, we were launching it. And the 11th of April, I came down with COVID. So that was great. So then after that, I thought, okay, got done the 7 days isolation. I can hit this. So no, for 3 weeks, I had COVID brain. I'm trying to like present my PowerPoints online to organizations. And I had to stop them and say, I have no idea what I'm talking about. I'm sorry, I've got COVID brain. So, but we eventually got it there. We had to plan which events we're going to have to host this It's Your Right campaign, and some outreach, point of care testings, and like how we were going to give out the incentives as well. So I just want to share some of the advertisings in each region. So this is the Gold Coast. So we're quite shocked, like when I went around and stalked public toilets, sorry, to find the advertising, pubs, shopping centres, any like buses. It was quite hard to see a bus. And then eventually I saw one, and it was like I was the passenger of the car, thank God. And we nearly smashed a work car. I'm just going to let that out now. Sorry, trying to get a photo. And I nearly got busted coming out of the public toilets taking photos. So we got out of that shopping centre real quick. But thanks to Tegan, we got one at the Coolangatta Magistrates Court. Good on you, Teags. Woo! I don't know if it's still there or not, but anyway. So it was quite fulfilling when I was going around stalking. So not stalking public toilets, but stalking the advertising, to actually see it up was just like, oh my God, all that work, like this looks friggin' amazing. So they're the advertising spots on the Gold Coast where we put them. Now we've got Brisbane Metro. So that's quite some of the photos from the advertising in Brisbane Metro. This is a great one, which was at the main central train station as you buy a ticket and get onto the train. So that was really cool. I had to bribe the security guard to let me in to take that photo because it was closed. They wouldn't let me in, but anyway, we got there. So we had some at the Logan Shopping Centre. So once a month, we do a point of care testing blitz at Logan NSP. So it was good to have those advertisings across the road at the shopping centre. We also go out to Caboolture and Redcliffe and do point of care testings as well. So we thought we'd put a little bit of advertising out there as well. And there's the Sunshine Coast. And there's Townsville, which was pretty stoked. They got more photos of buses than I did, but anyway. Also, we had some free advertising. I don't know if I can play this. Can we play this? Oh, no, we can't. Oh, anyway, so there was a weather report and I eventually saw the bus going past in Townsville. So I was like, free advertising on Channel 7 or whatever it was. So I was stoked. So I had to go in the next day because I missed it and Google all the newses and quickly like tape it for myself to show that we got free advertising, which was awesome. So also in Queensland, I was one of the participants that did my personal story for the It's Your Right campaign and got filmed. So my story was on Tonic Media Networks or My Doctor TV, which is those silly TVs in doctor's surgeries where you sit there and watch these repetitive things. But hopefully mine was joyful. I did have one lady that was ringing up for her son saying, I saw you on the television at the medical centre. So that was one good thing. Also, the mobile murals. Is this video going to play? I hope so. Anyway, so we had a mobile mural going around. It was just big advertising on a truck. So when we had to decide where it was going to go, Amanda, my project manager, and myself had to go, where the heavens are we going to send this for a week? For like 14 days it had to go for, and we needed to set where it was going to go. But lucky, the people that were employed to drive the mobile mural, there was only 2 people. They were unbelievable. They educated themselves on Hep C. They educated themselves on the It's Your Right campaign. So they were like talking to people all the time when they'd stop and people would come up to them. I'm hoping. So I don't know, can we play that video? No. Are you serious? Oh, shit. Okay. So anyway, this was a video and the video is of them actually painting the mobile mural. So it was amazing. They had people around them. It was parked out the front of our Bowen Hills office. So I'm spewing, we can't watch it, but anyway, okay. It's on Quinn TikTok, I just found out. Yeah, there you go. So it's really good that like it was all hand painted. The Aboriginal Torres Strait Islander design, which was on the other side, wasn't hand painted, but it took them like all day and all night to do. So that was good. It brought a lot of conversations with people walking past because when they did it, Quinn was closed. So yeah. Anyway, so this is some of the merchandise. We've got lovely Tegan laying there, woo, you know, posing for our merch. Yeah. So we had to decide what events we were going to do. I thought to myself, what the heavens, I'm not an event coordinator. I don't even know this stuff. But anyway, we eventually came up with, we've got an It's Your Right night. We've got there where we're at some Queens, we're at Queensland Parliament House. So, oh, that's not the photo. Hang on. Do we have the photo? We've got the photo somewhere, but we've got a photo with the health minister. So these are just some other events. We even had a DJ ripping it up. That was a really good day with the It's Your Right. We've got Tegan with the owner of PRS, which is an OST prescriber and dispensary, which was great, where she did an event. And we've got beautiful Tegan's pharmacist friend who decided to put posters up in her pharmacy, which was amazing. Okay, so then we had to decide which point of care outreach testing we were going to go. And so we went to an OST doctor surgery. Well, it was only one doctor really, and set up OST. Now the surgery, I have to explain, is full just white. It's old. You feel like you're going to go through the floorboards. So having some bright posters put in there was marvelous. We've got we really succeeded to point of care testing there, and we do it every month there as well. And the posters haven't been pulled down, which is good. So also in Townsville, they go out to Palm Island. So I thought I'd show some beautiful photos of them going to Palm Island on the plane, the views, and this is how good they go on Palm Island. Just have a little nap, you know? Good on yous. So now we did heaps of social media. There's our beautiful photo of Amanda, Dorrit, and myself, and is it the health minister? The health minister. So that was really good. Also, we've got some other advertising. We've got our beautiful Nikki in Townsville pointing up because she eventually saw the sign for the first person. And we've got the mobile mural and the Sunshine Coast advertising. So here's our Quinn staff. Some of our Quinn staff wearing the It's Your Right t-shirts. Represent. Good on you, staff. That's good. They still wear them. So it was really good to have group photos of each region as well. I'd like to thank you to Emily, Louise, Shannon, Troy, and Amanda for all your help through this campaign. Thank you.
Lovely. Thanks, Isha. Next, I'd like to invite Rochelle from NUA up in New South Wales to join us by Zoom. She's going to talk through how the campaign was implemented in New South Wales and coming to the end of the campaign. It's still in action. All right, I'll hand over to you, Rochelle. Thank you.
Thanks, Emily. Can everybody hear me okay? All right. Okay, and can everyone see my screen? I'm just going to press ahead. So hi everyone, I'm Rochelle, I'm from NUA. We rolled out the campaign in New South Wales, and so I'm just going to go through some of my slides here. Just before we continue as well, I just wanted to acknowledge Aboriginal and Torres Strait Islander people as the traditional owners of the land which we meet today. For me in Sydney, that is the Gadigal people of the Eora Nation. I just want to pay my respects to elders, past, present and emerging, and acknowledge that sovereignty was never ceded, always was and always will be Aboriginal land. At NUA, I also just want to mention that we do a community acknowledgement. So NUA is a community-controlled drug user organisation. We represent the voices and needs of drug using communities in New South Wales. And we were instrumental in averting the HIV epidemic and remain central to improving the health and human rights of people who use drugs illicitly in New South Wales. So I'm just going to go through, some of the slides here that we've got. Here are just some photos on the screen here of some of the advertising that was displayed through the It's Your Right campaign in New South Wales. In terms of our campaign implementation, we launched our campaign on the 15th of August in 2022, and that was rolled out in 2 locations. So we had South East Sydney Local Health District in Sydney. We rolled out the campaign at our NSP, which is a primary NSP in Surrey Hills, Sydney, and also through the Haymarket Foundation. And in terms of the other locations where we rolled the campaign out, it was also done in Hunter, New England Local Health District, which includes Newcastle and Taree, and that was done through our outreach activities. In terms of incentives for the campaign, we were providing incentives of $20 for testing and a further $10 for people that were coming back to get their results. But that was only for DBS, not for point of care. In terms of treatment initiation, it was another $20 for people that had received a positive result, and then a further $20 again on completion of treatment once they reached SVR. Now, in terms of South East Sydney Local Health District, there was 2 locations where we launched the campaign. One was at our primary NSP in Surrey Hills, as mentioned, And we also did outreach to the Haymarket Foundation. So the Haymarket Foundation supports people experiencing homelessness. And we attended the Haymarket Foundation on a fortnightly basis. And that was done through DBS testing. And in terms of the results from South East Sydney Local Health District, we ended up doing 32 DBS tests. We had 2 positive results and 1 person has initiated treatment. And in terms of our Newcastle results, we did 3 outreach trips across 4 locations. And that was done through point of care testing and also DBS. And for people that tested positive on either DBS or point of care, they were referred to the local health district for treatment. In terms of Taree, we did 2 outreach trips there across 4 locations. This was done in partnership with the Taree Community Health Centre and also Birrapi Aboriginal Medical Service. Merchandise was distributed to consumers at both locations in Taree and Newcastle. It was done through point of care and the testing was point of care and also DBS. And again, people were referred to LHD for treatment. In terms of Hunter, in total, we did, I think it was 362 DBS or point of care tests. I'll go through some more of the figures in terms of how many people tested positive and were initiated onto treatment. But this was done through, I think, I mentioned it was 4 locations. So we had Hunter Homeless Connect, ABC Pharmacy, which is two locations in ABC in Newcastle. Some of them would, the ABC Pharmacy, we focused on pharmacies that do dosing. And we also targeted Soul Cafe, which is like a homeless service. And in terms of Taree, we focused at Taree Community Kitchen, which is a homeless service. And we also partnered with Taree Community Health and Birrapi AMS in Taree. In terms of the peer engagements, as mentioned, there was 362 tests that were done through a combination of point of care and DBS. In terms of engaging Aboriginal and Torres Strait Islander people, there was a total of 180 engagements with Aboriginal and Torres Strait Islander people. In terms of the results for testing, so far we've had 102 that tested positive on antibody tests, and then that resulted in 32 that were RNA positive. And in terms of the results, we found that there was a higher prevalence of Hep C among people that were tested in NSP and OTP settings. Compared to, I guess, some of the homeless services that we engaged. We had a really, really good uptake of people that were tested in terms of Aboriginal Torres Strait Islander people that were tested. And yeah, we also had really positive feedback in terms of their peer engagements as well. In terms of our successes and challenges, I guess the major success for us was the authentic peer engagement that we had from using peers to engage people. And that really kind of gave us a really good expand of reach. One of the other major successes we found was the multi-agency collaboration. So partnering with community health centres and also the Aboriginal Medical Services. The merchandise and incentives was another huge success. I think Emily mentioned before, it was really positive for us to be able to engage people using the incentives and also the merchandise. And it was also really positive to be able to hear some feedback from some of the other peer-based orgs. I know that Queensland, South Australia and Northern Territory were the first to launch the campaign. So hearing about some of the successes and challenges from some of those other peer-based orgs was really, really beneficial for us rolling out the campaign. In terms of some of the challenges, obviously with DBS, there's a bit of a loss to follow-up. So that was a bit of a challenge for us, just engaging people to put them onto treatment. Another issue that we had, I guess, was trying to get some of the samples and also engaging people for testing beyond services that we're providing. So the NSP national data collection that we also took part in was a bit of a challenge, I guess, for us, trying to have those conversations with people to get them onto treatment whilst also providing other services. In terms of the timing of the advertisement burst, I've listed that here as a bit of a challenge for us. Basically, the campaign launch that we did, it was really great for people to be able to see the advertising and so forth. But we actually did get a few inquiries for people that had seen the advertisements after we kind of moved on to another area. So I guess the challenge was that for us was trying for people that wanted to get tested and get treated, you know, if we'd already moved on to another area. And then I guess the last challenge that I've listed here was the peer engagement and data capture. Obviously, with some of the engagements that we had, like I said, 362 people. It's a lot of information to capture. So getting all that done in a timely manner was also a bit of a challenge. So I'm going to wrap it up there. I just wanted to, before I continue, is just acknowledge the support that we've had from EC and Burnett, and also for the Paul Ramsey Foundation. But I also just wanted to acknowledge some of the partners that we had in helping us roll out this campaign, including Hunter New England Local Health District, who were phenomenal in providing support, and also some of the other partners, including ABC Pharmacy, Hunter Homeless Connect, and obviously the work that we had working with Birrapi AMS as well. And yeah, if anyone's got any questions, I'm happy to provide any more information. Yeah, I'd just like to hand back to Emily and EC. Thanks.
Fantastic. Thanks, Rochelle. Great to see you on Zoom and have you part of the presentation. So that completes our case studies, but I would just like to highlight, you can see, gives you a taste of how everybody's done it in a different way, and everybody's got knowledge about how it's worked in their local area. So please let me know if you'd like to be put in touch with the implementing organisation for the state or territory. Last off, before we shift into our panel, Louise is just going to give a brief overview of what we're collating for evaluation. So I invite Louisa from the EC Australia team to come up.
Hi, everybody. For those who don't know me, my name's Louisa Walsh, and I started with ECA in March, at the very start of March this year, to come on and do the evaluation, primarily the It's Right program, and we'll see what next year holds in terms of evaluation, but that's my focus at the moment. So this is just really quick. Unfortunately, we're right in the midst of data collection, and I know there's people in this room who've helped out with that and been part of interviews and focus groups and all that sort of stuff. So I'm not going to give you any exciting sort of, you know, information about what we're finding yet. I think my interesting presentations will happen next year once we've done all the analysis and the collation of all the data that we're getting. But this is just to give you a sense of what we're doing and how we've kind of led into this evaluation. So I just wanted to give you a bit of a timeline of how the evaluation was developed. And I think it's important to understand that it started from the co-design. So there was a co-design element to the evaluation where a theory of change was developed with the National Reference Group. And that's really been strongly used to inform and guide the development of the evaluation plan, the evaluation questions, and then the activities that we're doing as part of the evaluation. So it was April 2022 that the evaluation plan was finalised. And then it's not been until September that an ethics process was finalised. But that's been really important for us. We actually ended up going not only through the Alfred, but through 4 different state and territory Aboriginal specific health research ethics committees. And what that allows us to do is it allows to report on data specific to Aboriginal participants in particularly our client survey. So it means that we can report on that data with confidence and with the acceptance of the Aboriginal community. So that's a really important process for us, and it's been really valuable to do. As I mentioned, we're in the thick of evaluation data collection. I'm getting all the implementing organisations sending me spreadsheets, and I'm talking to a whole bunch of people, and the implementers are also getting clients to fill out surveys. So it's all sort of streaming in at the moment, and I'm getting lots of really exciting information coming through already. So I'm really looking forward to when I can share that with you next year, early next year. I'm not going to run through this slide in its entirety, but just to say that this is a bit out of the evaluation plan. And really, we're looking at a very comprehensive evaluation that covers off both the process of the co-design, the process of implementing the campaign. So what that was like, what different organisations did, what it was like for the people actually doing the work, and how we can use that information to improve future campaigns. And then we're also looking at outcomes as well. So, you know, did we see an increase in testing and treatment numbers? Were there any other outcomes for organisations or individuals involved in the implementation as well? So this is just a rundown very briefly about the different activities that we're doing, and we'll give you a sense of the amount of data that we're going to have to share with you. So we're doing service level testing and treatment data. And so the organisations who've been implementing have been collecting spreadsheet information on the number of interactions that peers involved in the It's Your Right campaign have with their clients, clients referred or tested on site, clients accessing treatment, and then even some clients who are moving through treatment during the campaign period and getting their final results as well, and how the services are using incentives. We also get an activity report from each of the organisations that tells us actually what they've done, and we'll use that as part of the evaluation to be able to say all the great events and things that our partners have been doing. The client surveys are surveys of people who are going to the services that are implementing the campaign, and it's really looking at, have they seen the campaign? What did they think of it? Any feedback and any action they took as a result, and a bit of demographic information so we can see the types of people who are visiting the services and seeing the campaign and what they think of it. I'm doing focus groups at the moment with people involved in implementing the campaign to learn about that experience. And I'm also interviewing, and Shannon as well is helping out with the interviews of people who are involved in the co-design process to understand what it was like being a co-designer of the campaign. And then we have a whole bunch of data on the reach of the advertising that comes from the advertising company. And also we have reach data from social media as well. So I think you can see there's going to be a lot of stuff to say early next year. But I really just want to thank everybody who's been involved in the evaluation. It has been a lot of work for the implementing organisations. It's not just me, it's not just Shannon, it's not just the ECA team who are gathering this data. We couldn't do it without people on the ground, just like we couldn't run the campaign without people on the ground running it through their organisations. And so I really thank everybody who's been giving me that data, who's been participating in the activities, who's been gathering client surveys, doing all that really hard work so we can really say something about what this campaign does, and we can use this information to shape up what it looks like in 2023 and beyond. So thank you to everybody. And I think now we're going to move into our panel discussion. So can we bring Rochelle back on screen, please? Yep. All right, when we have Rochelle back up. So we're actually going to open, we have some questions if no one else does, but we're actually going to open it up to the floor. Oh, we haven't quite got to Rochelle yet. So if you have any questions for Sal, Isha or Rochelle about the campaign, about their experience of it, about something else, then please put up your hand, and I think Liz, oh no, Anna has the microphone to come in and get your question. No, we need a microphone up here. So it is you. And if you're online and on the chat, just put your questions in the chat, and someone can convey your questions to Sal or Isha or Rochelle. Oh. Yeah, it's a relay.
Hello.
Yep, you're all good.
Hi, Yumi Sheehan from the Kirby. Really exciting work that you guys are doing. It's really nice to hear about all of the health promotion campaigns that are happening around the country. My question was for Salamander, actually for all of you, but mainly for Salamander, because you did have some treatment data in your slide. So I noticed that there were quite low numbers of treatment uptake. And I was wondering what you would do if you were able to continue this campaign. What would you do differently next time to try and improve or increase that kind of treatment uptake or the linkage to treatment?
Oh, thank you. It's quite indicative of the population of the NT that's showing in our stats, but also the NT was not used to having a campaign like this, and also with the campaign only being run for 12 weeks, that's the treatment time. So some of our stats, we were discussing this yesterday, flow over into results that are, people are finishing treatment now. So it wasn't a very good, sorry.
So what do you think would help with, I guess, keeping those people engaged in the NT, given all of the challenges and the barriers? How do you think we could?
Well, simply a longer span of time from that campaign running, but also, Brett, it was a first go at it, and we would really hope to have another go at it because we feel like it'd be a far more well-oiled machine second time round. We didn't know. Angie and myself came into the role. The clinic had been running. Everything changed once we come on board, and then the campaign started, and it was sort of like we were flying by the seat of our pants. And our number, I think our numbers are low because of our population as well. Yeah.
People that we treated and the number of people that were positive, it was actually quite good. So even though it looks quite small, that's our population. So
Thanks.
Hey, this is a question for everyone. I'm Megan. I do the nurse role in NSP clinics in Tasmania. Just wondering, so we've just finished our little burst in Tassie. The NSPs look great with all the posters, all the merch. Well, most of it's gone, but a lot of the posters and stuff. Are you guys going to keep the posters up, or are you taking them down and then bursting again, or what's your plan so I can steal it?
Oh, okay. Well, we've kept all our posters up, and all the organizations that we gave the posters to are up. Like, I feel that we've had more inquiries from other organizations now, and it's amazing, like, even though we're all in the same sector, that they didn't know about it when it was launched. And it's amazing how many emails and phone calls that I received regarding the campaign now. So one huge thing was that the Pharmacy Guild put our poster in their newsletter and wants all pharmacies that supply needle and syringe packs to have one of our posters up. So that was like a huge thing. But yeah, so we're just going to keep them up, even though we don't have the funding. Like, it was only 12 weeks of the funding, but I feel that the campaign can just continue.
Yeah, the same for us. We'll be keeping all of the posters up, and just none of the info changes. We're all still there on board staffing it. So
Rochelle, do you have anything to add to that? Did you hear the question? You're on mute, Rochelle. Yep. We might move on. Should she be able to hear us and respond? Yep. Okay, she might be busy, called away or something. Any other questions from the floor? Oh, come on. Good work, Jackie.
Hello. I'll keep it really short. Everyone that knows me knows I will ask 1,000 questions. So I was actually for Rochelle, but it doesn't look like she's here. The numbers that she had for the First Nations population was actually really deadly. And I was actually going to see if that was due to the fact that she had a good relationship with the AMS or the Aboriginal Medical Service. There, I did notice that there was a lot lost to follow-up contact, and I was wondering whether it was due to the community members returning back to custodial settings or going back to country for sorry business, and if there was any like brief interventions prior to treatment, and then what would happen with those First Nations people, and if those considerations were taken into consideration, I guess. Yeah. Thank you.
Mary.
Thanks for that question. Those numbers reflect kind of typical numbers for our service. But we did put a lot of effort in Hunter New England into building relationships with the services up there and the local services. So we had a peer, I don't know if you noticed on the bus, I hope Rochelle wasn't ready to answer this question, so apologies in advance, Rochelle. So the one of the peers on the bus that traveled up was from Hunter, New England. So that undoubtedly helped. The treatment question is a really good one. And we find that that's the case across settings. So it's not specific to Aboriginal and Torres Strait Islander people. And going to your point, the positivity rate is only about 10%. So any of the treatment follow-up numbers you have to keep that into account. But it is hard to get people onto treatment. And we're just having that internal discussion right now around the incentivization, around contacting people, because it is like, I don't think that it's specific to NT. Like we have the same issue in the inner city in New South Wales of people not having phones, et cetera, moving around. But that is kind of what we're focusing on at the moment, is that converting the testing numbers, which are amazing, into treatment numbers.
Sorry to take it over. It's going to be karaoke tonight at my place. No, thank you very much. But I'm just thinking for from all the, from Queensland, because it's such a big area. So remote and regional areas, Ish and Queensland done really well. And so did, no data. I'll get it from Amanda. But the one thing I was thinking of was, like you said, there's some of those barriers at the very start. So were those participants, were they provided with brief interventions from the peers or the clinicians to seek social health, while they were on treatment? Or did the peers, so at Quinn, they have a TMP project or the peer project to work through them with treatment? So I know every state and territory is different. In Brisbane City, where I'm from, with the Institute for Urban Indigenous Health, we have I'm a care coordinator now, so I actually started at Quinn, but now I'm over there. So what I actually noticed was I'm able to get phones and do a lot of other stuff as well. So we have connections with Murray Watch. If they return to custodial service settings, we can get their medication taken into them straight away with the elders. It would be really good if that was across the board for our multicultural brothers and sisters and other community members. That should be mainstream, I guess. But is there anything that's happening out in the Northern Territory or Queensland in the regional areas like Palm Island and that as well? And that's my final question, so sorry.
Don't apologize, Colin.
From what I understood of part of the question was we pick up when some people are released from prison, and we make sure that our flyer is in their release package, so they've got the information there. During the 12-week campaign, we continued on as we had been under the bigger EC project, which was walking with that person through treatment, regardless of background. We engaged with Indigenous health services where that individual was engaged with them. But what we find a lot in such a small population in the territory is that it's a lot of the Indigenous people don't like to go to the Indigenous health service because auntie works there, their cousins work there. So quite often we were sticking with delivering that really loose grassroots case management right through to the end of treatment. Does that have, that was a long question, sorry.
I just wanted to have a quick question about the posters. I really like the information you gave out to go along with the posters. I think it was good for services when they had the posters. If a client asked them about what this meant, they could actually answer. So we had lots of positive feedback around that. And also services were learning a lot about Hep C and what it is and the tablets and treatment time. The other two things I wanted to mention too, we get a lot of comments about the 8 to 12 week poster for the treatment time, and also about the no shame in getting treatment again. I think those two are really have a lot of impact in mainstream services as well. That was just a comment while I'm buying time for Amanda to find some data.
That was the most stolen poster, was the get clear on the gear. And we would happily replace those each and every day if we had to. And it just really, it gave our injecting drug users a campaign to own. They felt that we were using their lingo. It was comfortable and, you know, a bit cheeky. And we gave those T-shirts were the ones that all the clients were asking for. They love strutting around with get clear on the gear on there. So it was very clever.
I think one of the main things that came out of Queensland was when we did the Aboriginal Torres Strait Islander burst, we got so many comments from like a range of people regarding the design of it. And like, it's amazing the normal posters are just bright and stuff, but I feel that wearing the Aboriginal Torres Strait Islander burst of T-shirts and stuff, people just absolutely love them. They love to know that they can get do treatment as many times, you know, so there was a lot of shame regarding that you can do treatment once. And as for you guys, everyone loved to get clear eye on the gear. So I think that was good that we all came together and put that up as well.
Oh, thank you very much for sharing all your fantastic work. It's very motivating. I'm Louise from Tasmania, but I'm wondering, is there a national health promotion conferences, and will you be able to showcase your work? Because obviously we see health promotion across so many spheres, whether it's quit campaigns or this, that, or the other, because wouldn't it be great to share this work? And is that a possibility?
Yeah, we're definitely looking at options for sharing the work. And obviously, you know, we're very connected into conferences that are within the sector, but I think, yeah, exactly right. Sharing it more broadly, particularly such a strongly co-designed approach, you know, is quite unique, but also then this sort of combination of designing the assets and then having implementing organisations, many of whom were involved in the design as well, taking it forward is probably a bit unique as well. So yeah, definitely a good suggestion. Thanks, Louise.
Can I?
Yeah.
I just wanted to say about the merchandise prompted conversations really smoothly about taboo topics, which is safe shooting practices and stuff like that. And sometimes we got a couple of comments about how the tourniquets didn't last long. And it's like, well, that was the ideal opportunity to say everything should be single use and talk about that sort of stuff. So it gave us ease of access to some sticky topics. And it was just fantastic. I think they really loved their own merch packs coming out of the NSPs.
Where the slide went, sorry. So between April, the 11th of April to the 25th of July, we did 348 point of care tests. 63 of them were HCV detected, and 31 of our clients started treatment in that frame time. So that's what happened in Queensland.
I think we have time for one more question, and Troy's got the mic. So
thanks, Louisa, and thanks to everyone who just presented. Great campaign. But this one, I guess, is for Emily, going back to the co-design and the principles of co-design. And I guess how pivoting to an online environment, how the principles of co-design were enacted for, you know, a two-year design period, I guess. And how was that done online, and what were some of the tools that were used in an online environment, I guess, to bring peoples together? And we spoke about how you know, not being able to come face to face, and you're unable to use face to face, I guess, mechanisms of storyboarding and that type of stuff. Yeah, so how is that some of the challenges, and what was used online to bring, you know, all the co-design principles and also the peers' ideas to the table, I guess?
Thanks, Troy. There's a lot in that one to unpack. I think one of the things in terms of going online, working well, was we actually paused our design work when the pandemic arrived and we were all starting to work from home. So that was a massive transition. And I think particularly for the peers working in NSPs, working from home was completely different. So we all paused our design work for, I think, 3 or 4 months. But what we did is we kept on meeting. So we had informal monthly meetings, and that's where we all got used to working on Zoom, working at the laptops, working at our sound, all those joyful moments where you're like, you're on mute, we can't hear you. And so we started to get a bit of a rhythm with each other, and then also sharing how we were going with the pandemic, what people were noticing within the NSPs, or what it was like trying to deliver a service when it's a bit chaotic. So I think that was a real benefit because we got to know each other, we got comfortable, there was no kind of pressure to be creative. So then when it came to the formal actual design workshops, which we started, we were ready, we were kind of already established as a group. And I think the other aspect was the National Able Peer Network. They were a pre-established group as well. So there was connection, relationships and trust there. And I think that was really important. So I think one of the recommendations, if you are going online, I think it's important for the group to be able to get to know each other before you get into that creative zone. Because yeah, it's quite different trying to think outside of the square when you're working online, or maybe it's just me, I don't think as well when I'm working online. So you always have to think, how does a person kind of be creative in that online environment where you're sitting in a room by yourself? In terms of the tools that we use, it was really important for us we had 20 people part of the reference group. So that's quite big for working online in a group. So we always split off into small groups. And that was very effective in terms of people just having the time and space to talk and not feel rushed. But having said that, we kept the design sessions short to 1.5 hours. We did start with 3-hour sessions online. That's too much. People can't concentrate, particularly when you're going from meeting to meeting all online. So we learned quite quickly that 1.5 hour sessions were really good, and working in small groups was really effective. But the other thing that I really found useful was I would call people on the phone. So I had many conversations like with Pete from NT, Colin from Queensland, Isha would always get a call from me on a Friday. Yeah, so that's the other thing with co-design is you've got your formal design sessions, but if you think about a workshop, usually you walk off to lunch together, you start having those spontaneous conversations. So for me, those spontaneous conversations became a quick phone call to one of the peers, kept on talking through the ideas, and you'd kind of discover it and then bring it back to the group. But the pivotal thing, or the significant thing for me for the co-design, was equal shared decision making. So for myself as a project manager, I did not make decisions outside the group. I'd always bring the key decisions to the group. And I think that's that was really beneficial to working together and having a very strong partnership approach. And I think that's where co-design is really good. Hopefully I've covered some of those aspects.
And I think that's our session to come to a close. And it's now lunchtime. We will be truncating the time of lunch just because we started a little bit late. But we're still coming back here at 2 o'clock. So if you want to speak to anybody, I'm sure Isha and Sal and definitely Emily and I would be happy to chat during the lunch break or dinner tonight. If you have any other questions, but I release you to lunch, I think it's good. And thank you to our panel members.